Well, this is new for the AOS, so I'm really happy to have you all here. We are at our annual meeting, which is the occasion that we're gathered together for. We're just gonna have a conversation about orthodontics, about dentistry, kind of about where things are in the world. But first, I'd like you guys to take the time to introduce yourself and tell us a little bit about what you do day to day.
And I'm Gary Schulman. My introduction is I am on my second career. I started out as an architect, then decided to change careers. A lot of my motivation, and maybe a bit of what we'll talk about today from my perspective, is my dedication to working with patients with special needs. I had a brother with special needs, and so my career change had a lot to do with that. So I went into dental school thinking about pediatric dentistry. I knew that it would afford me the chance to work with patients with special needs, but also do many different things, which I think is a neat part of what we can also chat about. You know, Matt, like me, does different things. I don't see them as completely separate parts of practice, and I don't see them as separate parts of patient care. I like the interaction between them. So I am in private practice in Connecticut, and I teach at the University of Connecticut. That's my true passion in practice. I really love teaching, and although I have strong relationships with partners and colleagues and patients and staff at work, I always see it makes me a better educator, having private practice. And I'm just happy to be part of the AOS, meeting really cool people like Matt.
Yeah, and so as a side note, as anybody who's ever seen him speak, you can tell that passion, that drive for it, I mean, it really comes out when he presents. So,
thanks, Matt.
My name is Matthew Standridge. I am a rural Kansas dentist, and I graduated from UMKC back in 2010. After worked public health for a little bit, then moved rural and decided that I wanted to really have as many offerings as possible in our practices, have as many services on my menu as possible, just especially since we didn't have access to specialists. And that played a big role in orthodontics and my continuing education going down that pike. And so orthodontics became, over the last 12 years, has become a huge part of my practice, starting with fixed appliances with regular straight wire braces, and then aligners, myofunctional therapy, started getting into airway, and then also a strong surgical component to my practice as well, a lot of surgery, sedation, implants, and then we also did a deep dive in dental technology. So I have a big boy 5-axis mill where we do a lot of our own in-house labs, everything from single teeth crowns to custom abutments to full arch hybrids, and we have a few digital 3D printers. Was kind of an early adopter of that back in 2017, and so all of that stuff has just kind of led me to where I'm at today. And now after quite a few turbulent years of trial and error, I finally fell in love with aligners because I did not at first, but then I went around the world learning the best from the best, and so now I speak on aligners, and my real biggest passion is ortho and airway and growing faces and that type of stuff. So that's where we're at now.
Yeah, and I'm Nate Porter. I'm the executive director of the American Orthodontic Society. And I think it's unique that both of you are educators, so you both see dentists as they're coming into knowledge about ortho, knowledge about dentistry, things like that. How do you feel people who are kind of going through that process of learning and acquisition, what do you see as kind of light bulb moments when it comes to this relationship to ortho and facial growth and that sort of thing?
Well, I guess my perspective is that of a pediatric dentist. So a light bulb moment, I think, is when a young pediatric dentist does what I was alluding to a little bit a couple minutes ago, which is that synthesis of different backgrounds, different fields of thought. And so I think residents come out of programs typically well trained, and and they can kind of check the boxes and pass the boards. but it's when you start to tie topics together and you start to let different aspects of the comprehensive field of dental care and pediatric dental care kind of feed into each other, help you make ultimately better decisions for your patients. So I think that is a true light bulb moment. But I guess there's another way of looking at it, which is, are there light bulbs that could go off kind of internally for young practitioners, young dentists, to say, wow, this excites me. Maybe those other aspects of practice they're important, but they don't excite me so much. This excites me.
Mm-hmm.
It's really neat to, it sounds cliche, but to give kids or patients nice smiles. Or maybe I just really enjoy, learning about mechanics and actually doing braces. So I guess there could be different types of light bulbs that could go off.
And especially going into orthodontics, there can be a artistic component to it. So if you're looking at somebody's smile and their smile curvature and their lip fullness and, doing all this stuff, it can be artistic as possible, or it can be almost as engineered minded as possible too when we get into biomechanics and everything. So it's kind of interesting. It's almost like can be almost like a choose your own adventure with that, right? It's just like if you find something that really lights you up, then being able to figure out how to hone in on that and focus in on that more and more. There's a lot of freedom in that that doesn't exist in a whole lot of other professions and a whole lot of medical professions. That free way of just like being able to hone in on a certain craft, you know what I mean? So it's pretty. I think the biggest thing for me, because most of my students are GPs. They're about 90% GPs, maybe 5 to 10% pediatric. But what's interesting to me, especially with the newer generation, right? Newer grads and stuff like that. And it's not to poo-poo dental schools or anything like that, but there's just so much to cover, and so many people come out just not really feeling sure about things. And it's kind of like that saying, they teach you just enough to not be dangerous, right? But then one of the things that I think continuing education as a whole needs to do, and this plays into what Gary was saying, is find a way to connect all the pieces, because still to this day, dentistry is still wants to be seen in little segments. Pedo does not talk to endo, it does not talk to, pros, does not talk to, GP and all that stuff. And I think getting out of that medicine 2.0 mindset or dentistry 2.0 mindset of just having these separate fields that are in isolation and starting to see the whole human being as a holistic, everything's connected together. And I think that's going to be the next wave of the profession, but then in retrospect, a reflection of that being the continuing education needs to have that holistic, component in mind.
Yeah, I completely agree from what I hear in our courses and from our members and that sort of thing. When you think back to when you started doing orthodontics, what are some sort of pivotal moments or changes, milestones, as you've sort of evolved to what you are today, what you do today?
Well, I guess there are two ways of looking at that. One could be, what were those pivotal moments where someone taught you something that was so critical, that it really started to educate you to a point of, more comfort, better understanding. And again, that can happen via a great teacher, a great mentor. I did have great teachers and mentors. So certainly Dr. Carapezza, for me, was one of the founders of my practice, was another, and he was just a brilliant kind of technical guy. But I'm trying to pin it down where I may have found that moment where I turned a corner and I said, I really truly get it. I'm not sure. I think it was more gradual for me. There was no, I don't know if I could pinpoint that, that exact moment in time. And I guess I have to be comfortable with that it was kind of a gradual process. Yeah, I mean, I want to give Matt a chance. I guess for me, it was when I started teaching. I knew I needed to step it up. I needed to make sure that I knew what I was talking about, and like all teaching institutions, it's got to be evidence-based. So I just had to dive deep into the literature and into what is well established. So even though that's also, it's not a moment in time, that was probably it for me.
I'd say mine was probably, gradual as well, but like I definitely had a pretty linear track on things. So I started my first exposure to orthodontics, and it's funny because I never really expected to do orthodontics. I have this funny story that I tell in my classes that, in our ortho lab, my bench instructor was the dean of the chair of the orthodontic department. And, our first thing is basically bending wire and salt and peppering a Holly retainer. And so go give it to her, and she looks at it. And I didn't quite get enough monomer, and so it had that cloudy look to it. It wasn't crystal clear, right? And so she looks at it, she looks at me, she looks at it, she looks at me. She's like, "Are you want to go into oral surgery?" I'm like, no, I'm not. Are you want to go into perio or endo? No, I'm just looking at being a GP. Oh, well, good, because ortho's not for you. Like a second-year dental student, and so ortho was never really on my radar. But like I said, being rural, I saw the need for it, and so I started with a friend of mine, Rick DePaul. He was teaching a 6-month braces system called PowerProx, but he didn't just do that. He was very technically gifted ortho guy. Like he could do so many great things. But that was what I call my gateway drug. But the beautiful thing of at least getting started on that was then I realized how much I don't know still. And then I was like, okay, now I've got to start taking the next step, right? And so then I heard at that time it was Garrity, and it was actually being taught by AOS past president Joe Schmidbauer. And they were that course was located in Tulsa at the time. And so I was just about 3 hours from Tulsa. So I was like, hey. And so I go down there, sign up for a course, go down there for 5 sessions, and then I come back for a second year. But I also start showing my cases. Then I come back for a third year and a fourth year and all that stuff. And I just keep kind of going and going and going. And so mine, like I said, mine was a very kind of linear track. But then it was also, I think I became a member on the AOS at 2013 or 2014. But I know my first annual meeting was 2014. And it was out in Denver. And so I remember that specifically. And so then that was just like, kind of 6-month braces, then basic, straight wire, and then attending the AOS meeting and getting exposed to different speakers at the AOS, but then also the members and starting to make connections there. And that's when I learned about Lenny. And so then I took Lenny kind of a not his full 5 session, but like his advanced weekend.
Yeah.
But it was kind of a linear path in that aspect of it. So
When you look back at your like early cases and stuff, are you like, wow, like I've really advanced?
yeah. But that's the natural progression of things. Like I have a saying that I tell people because like we can't let perfect be the enemy of progress, right? And we're never going to be perfect. Even to this day, I am not even close to perfect. We also kind of have to have the courage to suck a little bit at something new, but know that we're going to continue to keep working on it, refining it. Just like anybody, listening, their first class 1 composite probably wasn't that great. And it probably took a heck of a long time. But as we continue to learn and grow and get better and refine our craft, that's just the natural progression of any sort of mastery, wouldn't you say?
Absolutely.
What are your thoughts?
No, I agree wholeheartedly. As much as we'd like to say, upon graduation from school or residency, you're at the same level, you'll remain your career. It's completely unrealistic.
You hope not, right?
Right,
Sure.
and so you just do have to acknowledge that there's a progress. There will be progress. I do recall my first orthodontic patient in residency, and it was just the way it was. Our attending, who was not an orthodontist, because orthodontists kind of refused to teach non-orthodontic residents. He was a good guy, but he wouldn't leave his seat. And so all of us residents were on our own. And I knew I had to bracket a patient. I had no idea what I was doing. And I turned to the assistant, I said, do you know what to do? She was like, I don't know what to do. And I think I put the brackets on upside down, backwards, but that's what started a lot of this. I went back to the program director and I said, look, I know, you already have someone who's overseeing the orthodontics here, but can I give the residents a lecture on how to put a bracket on a tooth? Because I think someone should do that. And that was what started the whole thing, because I dove in and I said, well, I have to teach myself, created a lecture, and he liked it, and the ball kind of, went from there.
So you already knew how not to do it, and then you kind of went from there, and yeah.
And I guess I would apply that to many aspects. I mean, there are things. I mean, the other day I had to extract 2 wisdom teeth in the operating room. I had no choice. This was a special needs patient. For you, no big deal. For me, who's not doing that stuff, I had to kind of review, prepare.
Yeah.
That's medicine and dentistry. You'd like to think you're always in your lane. For the benefit of the patient, I couldn't just stay in my lane. Maybe I could have gotten an oral surgeon, but the coordination that would have been necessary would have been difficult. And so I did what I was trained to do.
I'm really, just thinking about, your journey into adding ortho to your practice as a general practitioner. A lot of people, their first exposure is, I think I should learn how to do this. Maybe they're referring out a lot of ortho cases, or they see a need for it. Like you said, you're in a rural area, you don't have a lot of options for referrals. But I think there's a big struggle, a big gap from, I know I need to do this, to actually doing it.
Yeah.
Especially if you're a solo practitioner, you don't have the support of a mentor or something like that. What do you think about that?
Well, I mean, it's one of those things that change isn't going to happen until the pain of staying the same is greater than, so for me, it was, I got sick of telling patients and telling their parents, go see the orthodontist, and then seeing them in 6 months or a year, and I know they need treatment, and then they're like, and I asked, hey, did you go, talk to Dr. So-and-so? They're like, yeah, we went over there, but it's going to take 2 years, and it's a 2-hour drive round trip, and they got to do this every month for 2 years. I can't take that much time off of work. They can't miss that much school, so they're just not going to do it. And so I know this kid's wrecked smile is going to impact their confidence as they get older and all that stuff. And there are multiple studies showing the impact of straight teeth and a pleasant smile that has on a person's confidence, how other people perceive them, their job prospects, everything. And so it was just enough of that repeatedly that I was just like, okay, something's got to give. But I had to get to that point of just and it could be some people, it's just either they have an ortho in their office. Like, for example, another one that I hear from students is that they have an ortho around them, but they're really gung-ho on taking out teeth. But the dentist, the general dentist, doesn't really like that. They're maybe more airway focused or something like that, right? And we're not going to get down that rabbit hole, but they just have different treatment philosophies. Or they go and they're trying to set up a restorative case, right? And they're trying to coordinate with their orthodontist, but it's just not getting what the restorative dentist needs. Like, there's something happening going on there that's a disconnect. Now, maybe it's the disconnect that the orthodontist just doesn't quite know or really care about what the dentist really needs, because they're just going to plug them into their own system. Or it could be a lack of knowledge for the dentist himself, thinking this should be done orthodontically, when knowing realistically the mechanics that you're asking for aren't really feasible. And so, there's tons of different pain points when it gets to that. But that's ultimately what's going to drive somebody to finally make that change, at least in my opinion.
When you started doing it in your practice, was there all right, I'm doing this in first case, second case, or was there sort of I should do this. Let me just take one more session, one more course.
What it was, no, I started when I was going through that course. That's why I love, what we do with Brad's course at the AOS is because they have people come back and you can monitor for that second year. But the whole thing on like the Sunday is the case review session. And personally, I think that's where the gold is because it was like I knew right off the bat, and I think a big part of it too was the instructors. Joe was very adamant: get a case going, get a case going. Even on session one, get a case going, get records. Here's how we do records: get records, and the next time you come in, present a case. Just show records. And so that's what I did. And so, because you can perpetually always think, oh, I just need one more course to get started. I need to do the one more thing. And it's just like, you just keep putting it off, and it's just that.
So you kind of had stepping stones. You took one step,
Right.
low intimidation. You got your
Right.
records, and then you got some mentorship on sort of moving that forward.
Yeah.
Yeah.
Yeah. So I just started taking records and I go and I just present in front of the class and they would tell me, yeah, this is a good case to get started. This is how you do it. And that's why I like going to like a continuum, kind of like what we have and everything. But yeah, but at the same time, people have to have that implementation in mind.
Yeah.
Because there's so many people who will go to a class like that, be there Friday, Saturday, learn the mechanics, but then they'll skip out on Sunday where it's all the case reviews and stuff. They're like, I don't need that. It's like, well, that's where you're going to learn to either learn what to do or learn what to not do and stay out of trouble.
I love what Matt had to say. I mean, you were kind of anticipating what I was going to say. So I guess I would reinforce that by saying, let's say, you, Nate, are a young dentist, and you said to us, hey, I'm thinking about incorporating orthodontics into my practice. Very nervous, didn't get much training, now what? Without talking about like, oh, well, the AOS has these courses or that courses. I would say, and again, this is in line with what Matt said, make sure you do want to do this. If this is something that really you feel you can become passionate about and take it extremely seriously, that's step one, because you're going to have to commit a lot of time and money to this. And it's going to be stressful because of, the whole aspect of this could not go well. And then you have orthodontists ready to pounce on you. Putting that aside, saying you, Nate, are truly interested in going down this path, case selection is so important. What is the first case I would want to do? Hopefully a very straightforward, simple case. And that's kind of what Invisalign does too. They start with like case selection, like just a simple class 1 crowded, minimally crowded case. So start with case selection. The next thing is, and again, Matt alluded to this, it's records. You have to know how to get proper records, and records that are gorgeous and beautiful and helpful, and rely upon your records. And in today's digital age, yes, it's important, but it also is going to facilitate the next step, which is to then, as you go through treatment, hopefully you do have someone to turn to, and so, what you said is such a good point, that if you're going to do it, stay for that third day with Brad and say, Brad, here are the records, and hopefully, again, they're good records, so you don't spend time saying, oh, I missed this, I did get, so that Brad can then help you and say, oh, you know what, I actually just think it's a bracketing issue. Maybe I see you put your brackets on, but if you had done it this way, the bite wouldn't have opened, so much, or this, or why did you skip, this wire? Maybe you need to do this, or, did you remember to look at functional influences? Right. So having a mentor is important. And I think, another aspect is you do have to be very upfront with your patients, and in my case, the parents, and say, I'm not an orthodontist. This is my experience level. I'm willing to go down this road if you are. I do think what I've heard over the years is people will say, sure, I trust you. My kids like you. I trust you. And some will say, no, then we're going to go to the, the orthodontist in town. So those are just some steps I would take.
And he makes a good point. That's another reason why orthodontics is so great in GP and pedo offices is responding to patient demands or desires, because they have a connection with you. They know, like, and trust you. They don't want to be bounced around between other offices. So if you can provide that service to them at a high level of quality, then that is a win-win for everybody. But on the flip side of that is you have to know what you're doing, and what you can do, and almost more importantly, what you can't do. And if you can't do it, you have to have the wherewithal and the integrity to say, that's outside my zone, and you would be better served, by going to my, friend
Yeah.
over here.
Yeah.
So.
Yeah, and I think just to reiterate what both of you have said, how important case selection is, and which is why you take those initial records and you bring them to the course. Because I've heard many times, you shouldn't touch that case with a 10-foot pole, that's way outside. And I've also heard many times doctors maybe bringing records and saying, I don't know, does this need treatment? And Dr. Williams will help them to understand that that's a perfect case for you. So their diagnosis of, treatment is better tuned because they know what to look for. They know, things they may not have even seen before. Now they're seeing, and they're,
Well, I think you sat in on my last aligner session
Yes.
here, and day 2 morning is case reviews and stuff. And I probably dissuaded half.
because it's obvious to them. They're like,
Yeah.
oh, that really needs ortho. You're like,
Yeah.
yeah, but not for you.
Yeah,
Not right now.
exactly. Yeah.
I was going to ask also briefly, just, when you alluded to this, but as a general dentist, as a pediatric dentist, as their primary provider of dental treatment, what advantage does that give you as someone who's providing orthodontics to the patient versus a specialist where they're going for the first time and they're going for the limited treatment and then they're back to their primary provider?
Yeah, it's a great question.
It's that comprehensive treatment planning that you can do. It doesn't even necessarily mean that it's at the exclusion of another provider, another specialist, but I think it makes you a stronger practitioner because you can see things comprehensively. So I can give one example, which is, again, for me, it's going to the operating room with a special needs patient. Even in cases where I'm not considering any kind of orthodontic movement, any kind of orthodontic treatment, but I'm still able to wear the hat, that we're trained to wear here, to say, well, wait a minute, what else is going on for this patient, and how can I organize myself and my plan using my orthodontic training? And so I think that I therefore can become a better overall practitioner and see that patient's care, very holistically.
And I actually want to piggyback on something that you just said, and tell me if you agree or disagree. But like, for me, learning orthodontics, out of all the little subfields, subdisciplines of dentistry, learning orthodontics elevated all the others. Like, nothing made me a better, more well-rounded practitioner as orthodontics did. Like, orthodontics, it, obviously made me better at ortho, but it made me better at cosmetics. It made me better at restorative. It made me better at implants. I mean, it just, like, nothing lifted the boat, rise the tide of all the other fields of dentistry as orthodontics did. And I don't know if you would consider the same experience in pedo or not.
Totally, because, and I love what you had to say, I think it goes back to what you were talking about before. Like some other aspects of dentistry, you just go from A to B to C, whereas this, you can't. You have to train yourself to slow down. Obtaining records is so important because you then have the opportunity to go through your diagnostics and say, from different points of view, what's going on with this patient. And now I can formulate a treatment plan. We were taught to do treatment plans in dental school, and sometimes they were really complex, and sometimes you would get different people to help you. but maybe sometimes they were just really kind of financial treatment plans. They didn't have that wonderful complexity.
We're going to put out this fire first, and then this fire second, and it's just to me it was just always like tamping out fires as they came. It was never like a holistic, health-centric view. It was just kind of like pain management and disease control, but it wasn't as whole health-centered, I guess I would say.
And that's the architect in me had to remain. I had to remain an architect in some way, and that's it. Because your analogy was, there was a construction aspect to it, rather than just kind of, again, fixing, patching this leaky pipe and that. Instead, your analogy is, no. Let's design the whole thing, and then start to put everything together so that the end result is better for the patient.
To get back to your point of like from the pedo side, to the GP side, what's the benefit? To me, I think it's with general practitioners, they're the ones seeing the patient for the patient's life until they either move or die or something happens. And so it's not like when they go to the orthodontist, they see him for 2 years and then they don't really see him again. With GPs, you're tracking not only through the case, but then you're tracking things afterwards as well. And that also, in a way, puts a little bit more pressure on the GP to do a really, really good job, or else you're going to be seeing these kids every 6 months. And if you didn't, if you missed something. But what's nice about that, though, I will say, is that say you have relapse on a case, or you see something and you just missed it, like maybe they just finished a quarter step class 2 or something like that, but you keep seeing them again and again, and you can track their progress, you can track their stability, but it also gives you a chance to learn. And going back to what you said about records and wanting them gorgeous, is because when I did that and I'm seeing these people come back to me 2 years, 3 years post-treatment, and either they had some relapse or something happened, or just like as I got better, I'm like, this could have just finished a little bit better. So what and 9 times out of 10, it's something that I missed back in the early diagnosis stage. I didn't think of this thing on the Ceph, or I missed that. Like a practical story, for an example, when I was getting started, was I was looking at the molars for class 1 relationship, right? That's the textbook, is that, mesial buccal cusp of the upper first molar sits in the central groove of the lower first molar, all that we all learned in dental school. But, my teaching program taught the 6 keys of occlusion through, Larry Andrews. And he also talks about the premolars, looking at the premolars. But for some reason, my brain wasn't clicking on that, in the course. And so, and this is another reason I'm such a proponent of coming back, and monitor, because it's such dense information that it's drinking from a fire hose, and you can't absorb everything off the first end. But I know I was told that, but I put down that this patient is class 1. I'm going through arch wire sequence, and I come in, I'm checking things. All of a sudden, they're class 2. And I have, a Code Brown moment. Like, what just, what happened? Where did I mess up? And then, is one of those things. I went back and I looked at the records, and I look, and it says, well, certainly the mesial buccal cusp is in that central groove, but that's because it was rotated. But the premolars are actually half-step class 2. So it was a class 2 case all along. I was just myopic and looking at the molars, and I missed this thing diagnostically. Not a huge deal or anything, but that's like a great learning point of why records are so important, and to really like study them, especially at first when you're getting your feet wet. Really think about things.
Absolutely.
Think it through, like, why is this like this? And that's where the real magic happens. But
Yeah, one sort of off the wall thing that I thought of as you guys were talking is, orthodontics is a dental treatment that is kind of unique in that it completely preserves the tooth structure, and it extends the life of the teeth because you're getting those,
Right.
those
That's a great
those
point.
things correct, which a lot of dentistry is not doing
Amputated,
that, right?
it's surgical, and
yeah.
that's a good point. I hadn't quite thought of it like that. That's good.
Yeah. So I think the last question I'm going to ask you guys, and that is, as you kind of look at your journey and kind of where things are headed, what do you think is sort of the evolution of orthodontics? Where is it today different from where it was, and where do you think it's evolving into the future?
Oh, that's all Matt. This is the digital boot. This is the aligner boot camp. You know, like I mean, you're the tech and the aligner teacher. I can go hang out in the back now. Exactly. He sees the future.
I'll start with the tech, but I have a second component that I think you'll want to piggyback off of. Okay, so starting off with the tech, first off with records, like you were saying, now with everything digital, there's no reason not to have thorough, great records. I mean, can you imagine taking photos and then having to go to Walgreens to get them developed and all that stuff, and pouring up stone models and blah, blah, blah. It's just like, and dip tanking your Ceph and all that stuff. No, it's just, so records to me, it's a no-brainer as far as digital stuff, but the digital revolution is just going to continue to come. We're going to start seeing more and more things that are going to drive efficiency. And whether they be efficiency and diagnostics. So there's some great like indirect bonding systems coming out that actually merge, you take a digital scan, you send your STLs, and you take a cone beam, you send that. They merge that together, and they're looking at the tooth morphology, and they're looking at where the roots are and the root angulation and torque, and then they digitally place the brackets according to that.
Yeah.
Right? And so I think kind of that next level care. Also, I think you're going to see the proliferation of a bunch of systems that use AI to treatment plan, to track, all that stuff, and to remove as many touch points with the patient as possible, like basically reducing the amount of chair time. That is actually a benefit for both the office, dentist, and the patient, because the patients have busy lives. They don't want to miss more work or school than needed. And also from an efficiency and profitability standpoint, the less chair time a case takes in the office, the more profitable it is for the practice. And so, but I'm all for efficiency up to the point that quality starts to suffer, and then no more, right? And so efficiency is great up to a certain point.
Sure.
But so I see that being the future from a technology side of things, but then from a patient focused side of things, I see the pendulum swinging back kind of to airway focused, a lot more myofunctional stuff, kind of more centered around non-extraction, early treatment, stuff like that. And I know Angle started non-extraction, then you went Tweed that went with extraction. Now it seems like we're going back the other way. But now I see Ortho 3.0 being not just straightening teeth, but what muscle imbalances are there? Do we have a tongue tie? Do we, what's the diet like? Do they breathe through their nose and that type of stuff? And from a patient side, that's where I think Ortho 3.0 is coming. What would you say, Gary?
I agree wholeheartedly with everything you said. I think that's a good description of where it could go in terms of the focus on patient care. But yeah, I think, paralleling other fields, the large companies that have the ability to invest in AI systems will possibly create much change, exactly as you were referencing, that whether it's an Align Tech type of company who is able to gather the data from all of these Invisalign cases that have been done over these years, and then start to come back using AI systems to say, hey Matt, not only are we going to, give you a better ClinCheck, we can even give you a little bit more advice as you go. Hopefully not pushing us out of the picture.
Right.
It's like, we worry about Terminator. You know,
Right.
that's the worst.
doubt.
You know, that we could worry about. But you know, I worry about being pushed out. So I don't want to get into the negative. I want to be you know, optimistic today. Let's hope that, you know, AI can help us down the road.
Well, maybe when we get back together, we can have a check-in on that. See,
Yeah.
see if we're still here.
See what's all
Yeah.
going on. Or,
Yeah. Well, thank you guys both for coming today.
Thank you.
And it's
Thank you
great
for having us. This was
conversation.
fun.
I think, yeah, hopefully we'll do this again.
Definitely.
Yeah,
For
thank
sure.
you.
Thank you all.